Good morning. I'm Maria Tilden, Executive Vice President of Public Policy and Government Affairs here at Carefirst, and I'd like to welcome you all to today's discussion on addressing behavioral health workforce shortage. Unprecedented economic and social pressures caused by the COVID-19 pandemic have impacted our collective mental health. The pandemic required a change in our approach to care delivery, while at the same time, the demand for services continues to grow. Many are seeking treatment, but this is straining an already insufficient supply of behavioral health providers. As we think about how to strengthen the behavioral health workforce, it's critical to promote culturally competent care so we can meet the needs of diverse communities. Many communities of color and individuals living in rural areas have been disproportionately impacted by the pandemic and have a greater likelihood of having unmet behavioral health needs. In addition, reducing stigma around seeking treatment remains a priority to better serve those most in need. The ability of the healthcare industry to proactively address projected shortages in behavioral health professions is vital. Some of the historical barriers to accessing behavioral health care continue to exist today, but we have a unique opportunity to chart a new path forward. To ensure access to behavioral health, we need to address why this unmet need exists and how collaborative interventions are critical to solving this important issue. Today, Carefirst is pleased to convene this panel of experts to discuss ways we can strengthen the behavioral health workforce to advance access to needed care and ultimately improve health outcomes. And with that, I want to introduce you to my colleague and moderator, Carefirst Executive Vice President of Health Services, Stacia Cohen. Good morning, Stacia.
Good morning, Maria. Thanks for the kind introduction. I'm thrilled to be moderating this important dialogue today with you all. This is an area I care deeply about. I started my nursing career many moons ago, working in an inpatient locked psych unit and have worked intermittently in behavioral health for much of my career. It's an important topic. The collective anticipation created by the past 20 months, that frequent sense of impending doom, the economic, social, and personal impacts that we've all experienced have been devastating. And as Maria pointed out, continue to strain our behavioral workforce. One good thing to come out of the pandemic, however, may be the growing recognition that our physical and mental health go hand in hand, and that integration of support and care of our whole selves is critical to our collective health. There's also been a call to action around increasing cultural competence in both delivery and payment systems if we want to most effectively serve our people and communities. Care needs to be better integrated with primary care, chronic disease management strategies, and people's culture and background. Strengthening our behavioral health workforce, both in numbers and in practice, will be necessary to facilitate accessible, equitable, high quality, affordable healthcare, core to all of our mission. I'm excited to get started today and am thrilled to be joined by three amazing panelists, each with a passion for behavioral health. I'll let them introduce themselves and share a brief thought on their connection to the topic we'll be discussing today. Starting with Adrian Bridenstine, the Vice President of Policy and Communications at Behavioral Health Systems in Baltimore. Welcome, Adrian.
Thank you, Stacia. Good morning, everyone. It's a pleasure to be with you and be part of this important discussion. As Stacia mentioned, I'm Adrian Bridenstine, the Vice President of Policy and Communications at Behavioral Health System Baltimore. For those who aren't familiar with us, we are a nonprofit that serves as the local behavioral health authority in Baltimore City. So we oversee that entire system of care of mental substance use services within that fee-for-service Medicaid public system. In Baltimore, we serve over 78,000 people annually within that system of care. I am a social worker by training. I've been doing policy work for a number of years, so it's been a while since I've done clinical work, but the skills that we use in our clinical setting are often apply to working in the policy setting as well. And just again, thrilled to be here this morning.
Thanks so much for joining us. Next, I'd like to introduce Rasha Krishnan, the Executive Director of the Women's Center. Welcome, Rasha.
Oh, thank you. So nice to be here, and thank you for inviting me to discuss this very relevant and important topic. So I joined the Women's Center in January 2020. Fortunately or unfortunately, that was just about 6 to 7 weeks before the shutdown, and it was quite an introduction. But my history is really in healthcare. I have an MBA, I did consulting, I worked at Innova for many, many years and have been in all different parts of healthcare, but my passion has always been with mental health care. And at the Women's Center, we provide mental health counseling and domestic violence, sexual assault services in Northern Virginia and Washington, DC. And as a nonprofit, we make sure that ability to pay is never a barrier to accessing care. And thank you for having me.
Terrific. Welcome to the team this morning. And finally, I'm pleased to introduce the Honorable Mark Sickles, member of the Virginia House of Delegates. Welcome, Delegate Sickles. We're glad to have you with us this morning.
Thank you, Stacia. It's good to be here. I represent part of Fairfax County in the southern part. My district basically starts the Woodrow Wilson Bridge and follows the Telegraph Road corridor down almost to Prince William County. I am the chair of the Health, Welfare, and Institutions Committee and also the chair of the HHR Appropriations Subcommittee, at least for the next month. It's been an interesting journey being chair and being involved in healthcare over these years, where we have not done a very good job in the Commonwealth of providing the continuum of services that we need in the behavioral health space. We are over-reliant on our state hospitals, and right now I think there is a consensus gelling that we're going to make substantial change in the future, near future. We were about to, for instance, raise our rates a lot right before the COVID shutdown happened, and that's been a little bit of a delay. But now these services, as has been mentioned, are needed more than ever. And so I'm happy to try to talk a little bit more about what we're doing and what needs to be done in this behavioral health issue. So thank you and welcome to the audience who are listening to us today.
Well, thanks so much, everyone. I think we'll get started. We actually have a fair amount of content we'd like to cover this morning. We'll do our very best to have this be a discussion. Sometimes that works more effectively via Zoom. Sometimes it's a little less, but we certainly will try to have this engagement from everybody in the questions. So getting started, as we've almost all of us have mentioned, the ongoing pandemic has negatively impacted mental health and intensified the need for treatment. Vaccinations have helped reduce some of our collective anxiety, but what we've all experienced over the last 20 months will have long-term effects on our collective behavioral health and our collective, mental wellness. From your experience, how has the pandemic further strained the behavioral health workforce? And what strategies have you found successful in mitigating this impact as we think about caring for the caregivers? Ashna, I'd like to begin with you.
Sure. So, gosh, I could talk on this one question for an hour. There's so much to say on this one particular question. But I will say we all realized that while the pandemic has impacted everyone, it has not impacted everyone equally. And we see that women, and particularly women of color, have been disproportionately impacted. And that is really a lot of the population that the Women's Center takes care of. Well, we take care of men, we definitely take care of teens and children, couples, we take care of everyone. Certainly, we have noticed a significant increase in demand for our services. Last I checked, we had a 21% increase in our request for adolescent mental health services, a 25% increase in our request for domestic violence services. And with the shortage, the shortage of therapists and mental health care providers, our wait list is now at 200, which is the highest it has ever been in the history of the Women's Center. And we've been around for 47 years. So this is quite a challenge for us, honestly, in terms of how do we continue to meet the needs of the community. And certainly, you know, I see a lot of kind of what Virginia State is trying to do, and we really appreciate that. But one thing that I will say is that I noticed that a lot of the programs, at least some of the programs, tend to be focused on more rural areas or underserved areas. And so where we are, Northern Virginia, while it's not an underserved area, there are still so many people that need service. And so sometimes those programs like loan forgiveness and whatnot don't apply where we are. But yeah, so that's a little bit of some of the challenges that we are facing. And we are really reaching out to all our therapists and everyone in the community saying, you know, please come and provide some counseling to our clients.
Yeah, you know, you raise a couple of points that I think will be important policy things that we will talk about in the next hour. You also mentioned, you know, the shortage of behavioral health providers. So let's talk a little bit about how policymakers and other stakeholders could increase student exposure to behavioral health professions early in their career. One of the things we think a lot about is, you know, how do we shore up existing workforce, but also how do we begin to create a broader and deeper pipeline of new behavioral health practitioners to serve this growing need. So if we were to talk about some policy opportunities, such as the loan forgiveness program you just mentioned, right, which sound like have an opportunity to, you know, to perhaps broaden. What are some of the other opportunities we could leverage to develop our behavioral health workforce faster? Delegate Sickles, I'd love to start with you. You teed up that you had things you could share about how Virginia's thinking about this. That might be helpful.
Well, this behavioral health problem has deep roots in parity among behavioral health and other medical issues, always kind of being treated differently. And so we started working on that long before, or talking about it anyway, long before the COVID crisis hit, and we were in the process of raising our rates. So it's kind of a basic thing. We need to pay practitioners as much as the market demand for the services requires. So we do live in a market economy, and if there are less risky jobs that you can take, and jobs where you don't come home possibly with a black eye, or and make more money doing the other job, you know, we're in trouble. So we need to pursue any policy that values people that want to do this work and reward them. And I think since there's a workforce issue in every industry now, it's not just this industry. So we're in competition from every field, that attracting, especially in inner cities and the rural areas where there are shortages, attracting folks when they're in their youth, middle school, early high school, and you know, telling them and educating people on what the opportunities are. So people that have the kind of skills and kind of empathy it takes to do this work might fill the shortages in the places where they come. So it's not like going out somewhere to serve a medically underserved area for people that grow their own, so to speak. And that has got to be a long-term solution to our, you know, medically underserved areas. We are just starting our loan repayment program for behavioral health. The regulations are not finished yet. We're going to, for tier 1 practitioners, it would be a $30,000 per year loan repayment. for a couple years, and for the tier 2, which maybe is licensed clinical social workers or a clinical psychologist, up to $25,000 a year. But they would have to serve in these areas, and the regs aren't out there yet. So that we had to put the brakes on this when we did not know what our revenue picture would be like when COVID happened. Fortunately, and ironically, paradoxically, we have a $2.6 billion surplus right now. And in the middle of pandemic, people went shopping. So our state budget is very healthy right now, and we need to make sure we are fiscally responsible in anything we do in this and every other area. The governor announced a 10% pay raise for teachers 2 days ago. And so what the long-term impacts from a fiscal standpoint, but this is high on our list of priorities, and the new governor has campaigned on this. So hopefully we'll make some progress. And I know that was a little long answer, but that's what we're trying to do.
No, I'm not too long at all. You know, I would certainly invite if any of the other panelists have perspective about what else we could doing to encourage health professions earlier, and broadening the workforce certainly is an opportunity to weigh in here now as well.
Sure, I can jump in. One thing that we do at the Women's Center, we actually have a training program. And that has been wonderful for us. So students come and intern at the Women's Center when they're in their master's or PhD programs. And then they also come to the Women's Center as pre-licensed therapists while they're getting their hours towards licensure. And then many of them will stay on at least part-time as licensed therapists. So that has been incredibly helpful to us at this time, honestly, to have that built-in pipeline, that built-in sense of commitment to the mission of the underserved. And also we do a lot on trauma-informed counseling. While we take care of all types of people, one of our strengths is really around the trauma-informed counseling. So that has been a great way. So I think that if people could kind of start that pipeline even earlier, like talk to kids. I call them kids, when they're in high school, and start, interesting them in a field in mental health counseling. I think that would be a great thing to get them interested. Many kids, high schoolers, they don't even think about things like that, right? So I would say start getting them in a little earlier. And I have one request for Delegate Sickles, and that is if there's a little bit of a surplus, maybe that loan forgiveness can be applied to therapists that work at underserved nonprofits in Northern Virginia, because we truly are taking care of the people who don't have resources. So maybe they could do a little carve out for for therapists that are taking care of underserved people in Northern Virginia. So that would be my little request to you.
Stacia, this is Adrian. One thing I would also add in addition to what my colleagues has said is we also have to do a lot to prevent burnout. Working in this field is hard work, and it can be really draining for people. So focusing organizationally, focusing on things like wellness and supporting staff, whether it's through robust benefit packages or a generous PTO policy, or just promoting overall wellness as part of your organizational culture, it is part of, I think, helping people to realize that they need to take care of themselves. Again, we see a lot of burnout. One of the things, though, I do think that has been a benefit, at least that we've seen in Maryland within our public system, is the broader use of telehealth with the service delivery system. That has both helped our providers be able to keep the clients engaged in service, but it allows the provider to work from home, which again can be that work-life balance and supporting people with burnout. It's also a workforce, from a policy perspective, telehealth has been helpful with workforce and kind of tearing down those artificial, boundaries for where you actually have to be to engage with the client. So it is something that in Maryland, we passed legislation last year to make permanent in certain service lines. But I do think, the cat's out of the bag, and we've seen this applied across the healthcare system as a result of the pandemic, and it's proven to be a really effective way to, promote access to care and help with that workforce issue.
Yeah, that's a great point, Adrian. It also highlights that digital access is now access to health. And so as we think about the other policy implications that has, telemedicine is only effective if you have access to the internet to use it. And so, I think that we will continue to uncover areas that will be necessary for us to strengthen in order in order for there to be equitable access to a broadening array of services and supports. Maybe we can pivot on that, because I think, one of the topics we wanted to make sure we talked about some today was culturally competent care and serving populations in ways that are meaningful to them. So based on the Journey to Wellness, Mind and Body Story series that was also authored by Behavioral Health Systems Baltimore, social determinants greatly inform one's ability to be well and thrive, much like we just talked about. Behavioral health impacts us all in a really unique way, but providers have to be able to meet people where they are to build a sense of trust and connection. So can you discuss your perspectives on best practices and strategies that help foster culturally competent behavioral health providers? Adrian, as part of that world, I'd love to start with you on this conversation.
Sure, and thank you for highlighting our Journey to Wellness series. With this series, we really try to pay particular attention to the importance of meaningful relationships, feeling connected, and a sense of belonging, which overall it's essential for wellness. But to foster that cultural competence, study after study has shown that the number one thing that clients care about is not what training your social worker has had, what clinical theory or approach you're taking, but it's rather the rapport that you have with your therapist and that connection that you have with the therapist, and not just the therapist, but the organization as a whole. And it goes to being trauma informed, like Rasha was talking about earlier. From a clinical perspective, and as a social worker, if you are an empathetic listener, that'll help you with making that connection. And it's important to bring part of yourself to the table, which is a little bit different than, as I mentioned, I was a social worker by training. It's a little bit different than what they kind of train you about. You have originally you're trained about professional boundaries, but it's really hard to make that connection with someone if you don't bring part of yourself to your work. And we all bring part of ourselves to our work. So it's important to acknowledge that. But I think the other part that we're starting to see a shift with in terms of our education and awareness across the field is acknowledging that there's this inherent power differential in the helping relationship, right? The therapist is generally seen as the person in charge. But if the therapist doesn't take time to listen, you're really not being culturally competent. So understanding that power dynamic, I think, is key to cultural competence, but it's also key to promoting equity and really being anti-racist, which is a movement that we're seeing across our system of care. Our system has historically been very paternalistic. We are the professionals, we develop these services, we know what's best for you. And we need to shift our approach with that and bring our consumers to the table with helping us to think through how can we be more culturally competent. We need our therapists to look like the people that they are there to see. And within the public behavioral health system, at least in Baltimore City, roughly 80% of the people we serve are African American, but we have a workforce that's primarily still to this day white. That's not contributing to the cultural competence. So taking a look at our training curriculums, just some of the stuff that we've talked about earlier are some of the things that we need to be doing now, and planning for that and thinking about cultural competence within that context of being anti-racist.
Thanks, Adrian. And that brings to mind that it is not only going to be initial training in the ways you talked about, but it's going to be ongoing training and continuing education and best practices around, around continuing to move the entire field forward in this way. And that's not just the care delivery field, that is also the payment system as well. As we think about, we're all parts of a whole, right? But let's talk about continuing ed, and if we have a workforce that perhaps wasn't trained that way, how in fact do we continue to evolve our continuing ed in ways that help us more effectively care for diverse populations and advance whole person health. Rasha, I'd love to hear your thoughts about that. I know as we were prepping for today, you had lots of great things and ideas around what we could, should, and ought to do in this area.
Sure. So we had a racial justice task force that we started early in mid 2020. And one of the things that they talked about is training. And it really is very important to provide that training to the clinical staff and the administrative staff. So training, vetting, looking at training modules that look at cultural competency is important. We also have a monthly in-service training where we pick different topics that are of interest to therapists. And it is the cultural competence training, but it's all the different types of training that a counselor or therapist needs to make sure that they are current in their techniques and their methodologies for counseling, because it does evolve and change over time. Because remember before it was like that talk therapy, and I'm not clinical, so if I misspeak, please forgive me, but we've kind of moved to other types of training like EMDR and CBT and things like that. So I think as organizations, we need to make it a priority to provide opportunities for training so that our therapists can stay current and up to date on the various types of training. And the other thing that we do, Ashley, is, I said we have the student program. We have been working with different schools in the area to ensure that we have a diverse diverse student body. So for us, it's kind of expanding our scope of programs that we work with so that we are getting students from a more diverse background. And diverse can be cultural, it could be ethnic, it could be racial, just all different types of diversity, which I think also helps quite a bit as well. Some of this, one line, I'm kind of talking a lot, but I would say the last thing that we're really trying to do, or not the last, but one thing we want to do, we got funding for, was for a support group, for a women of color support group. Because as Adrian was saying, that we know to a certain extent, if the therapist that's sitting across the table or across the room has a more similar ethnic background, then that can help, or racial background can help. So doing a support group for women of color, I think just trying to have programs that are specifically targeted to different groups is another way to be more culturally competent in the care that we provide.
Yeah, that certainly is, I think one of the truths that we've all, that got really exposed during the pandemic, and that I hope that we aren't collectively willing to turn our backs on. Sometimes in crisis, people pay attention to things that once a crisis passes, people don't pay as much attention to. But, one of the areas that I think is out in full view now is the health disparities that we are facing. And that while, the United States has, arguably the best medical care in the world. And by medical care, I include mental health. That's part of our health, right? That is not unique and different from our physical health. But we've got the best care, but we've also got some of the largest disparities. And one of the places that becomes really, really evident is in behavioral health services and supports. And so as we think about that as a health equity issue and as an issue driving wider disparities, I think it's going to require us to continue to be more creative about how we and where we may need to deploy strategies to better leverage behavioral health care to address health equity. And so, as panelists, I'd be interested to hear your perspectives about how we can best leverage behavioral health services and supports and behavioral health care. So not just direct therapy services, but the ecosystem of behavioral health to improve health equity. Delegate Sickles, I'd love to start with you on this question, because this is really about an ecosystem. And I know that you had started to share some thoughts about this earlier. I want to make sure we pick up on those.
Well, I think that a lot of this is money oriented, funding oriented. I think that this is an opportunity now in the current environment coming out of this pandemic. If we are coming out of it, maybe it continues forever, that people talking about it all the time. I turn on the TV and talk shows, and everybody has been impacted by this in one degree or other. We have long COVID to deal with in children and other people who can't shake it. So how do we respond to that in the public sector? We have established some free community college programs for needed professions. We need to drill down on that further. Someone was just talking about training and make sure people are well trained throughout their career. That made me think I need to check in on that to make sure we have opportunities with people who are already social workers to upgrade their skills. So I'm going to check into that. I think that's a great idea. Better strategies. We need to value people and tell people they're valued when they're doing this kind of work. And we don't have that much at all. So that's part of our responsibility as elected officials, is to make sure we tell people and support people and develop programs that are targeted and evidence-based and trauma-informed. Those are the words that come out of my mouth a lot, and not waste our money, because we've got things that are historically done that aren't as effective as we have now. We've learned as we've gone through society. Let's stop doing the stuff that doesn't have a big payoff and only try to follow things that are producing results. And in most states, our Medicaid programs, we have 1.7 million of our 8.6 million people in Virginia on Medicaid, and they're mostly served by managed care, not fee-for-service. And we got to make sure our managed care companies are compensated to do this, and make sure they are providing these services in a comprehensive way, because their main job from our perspective, is to keep people in the appropriate level of care and out of the hospitals and out of the emergency rooms. And behavioral health is a big subject to get your arms around, to keep people out of emergency rooms and inappropriate and more expensive care. So we need feedback loops, where we plan, do, check, act, and we learn from it, and we change the way we do things, so we'll do it better next time. So those are a few thoughts I have. It's hard to do these things in government. Things are hard to change in government. It's a little bit easier in industry. In my company, we can change things when the boss says, "Oh, we're going to do it differently." But in government, we got a lot of bosses, and we've got equal branches that the new governors need to learn. They're just part of the one branch of the government. So it's a more complicated process.
Yeah, it sure is. Yeah, one of the things a theme that I'm hearing talked about today is, in addition to what do we need to do to strengthen the pipeline of folks coming in, but how do we also create the environment of continuous improvement? Adrian, you mentioned that, the field keeps evolving. It keeps evolving because the evidence of what works most effectively keeps evolving, just like any other field of medicine. And so I think, Delegate Sickles, to your point, how do we continue to expand evidence-based practice, and as new evidence comes in, continue to move the field forward so that we are, in fact, investing in those things that have demonstrable impact? I think will be really important for everybody. And then making sure that ongoing training and support and cultural competence training, especially as we learn what works best in certain populations, right? Because one size doesn't fit all. And I think that's, I think that's a continuously evolving area of medicine, and particularly evolving area of behavioral health. One of the other things I've heard mentioned a little bit today is both how do we respond in crisis and how do we respond in ongoing needs, right? And that we've been in what I've heard frequently described as sort of a collective and continual state of crisis for almost 20 months now. And that some of what folks are really suffering with is just being exhausted from that collective sort of waiting for the other foot to drop or the other shoe to drop all the time. And so anytime, you live in a sense of, with a sense of impending doom for any period of time, that just takes a toll on people and people's resilience and coping. And it also sends people into crisis faster. So one of the areas we haven't talked about yet is crisis care. In Maryland, the Health Services Cost Review Commission, the HSCRC, which is the hospital rate setting entity, recently invested in 3 behavioral health catalyst grant programs to revitalize Maryland's crisis response system. This included the Greater Baltimore Regional Integrated Crisis System, GBRICS partnership. One of the things we've talked some about is the skill set necessary for the behavioral health workforce. And so one of the things that as I've been hearing you all talk, I've been thinking about is, what is the skill set that's going to be necessary in the workforce to support the GBRICS program, but how might we take that program and others and look at how the best parts of those can be replicated in other areas. And how might that program and other integrated team-based care concepts further advance behavioral health across the continuum through the use of other paraprofessionals. And so, Adrian, you're really close to GBRICS and this team-based program in response to crisis. I'd be interested in your perspectives about where and how team-based care could continue to advance not only, the impact that we make, but how could that strengthen our workforce?
Yeah, that's a great question. And so I think you've highlighted a couple things for me. One of the other things that I think has come out of the pandemic, you mentioned this, 20 months of being in a constant crisis, is the greater attention and the need for more robust behavioral health crisis services in our community, because we're seeing people as a result end up unnecessarily, in our emergency departments or engaged with law enforcement. Just as, when the pandemic first hit, one of the things we saw almost immediately, like the next month, March was when the shutdowns happened. Then in April, we saw a 100% increase in calls to our city's crisis hotline, and it has remained that high. So it's over 6,000 calls a month to our hotline, where we used to only get around 3,000. It's remained that high since April of last year. So I think the evidence is there, to your point about how we're in this pending state of doom. But for the crisis services, one, we don't have enough. The workforce just isn't there. Partially because I don't think it's not been valued in the same way that we've valued other types of emergency services, like fire emergency response and police and our emergency departments. So now it's getting the attention it needs, and we're looking for the workforce and they're not there. But in terms of a skill set, working in that behavioral health crisis services setting is a bit different than working in your standard primary care office or even your outpatient mental health clinic, where you have a bit of, as a therapist, you might have a schedule for the people who are going to come in and see you that day. As a clinician working on a mobile crisis team, for example, you don't know what you're going to get, and you need to be able to be quick on your feet and respond in that time, and know, if I need to pull a nurse in to help with this response, or if I need to coordinate with our local law enforcement to help with this response. So it's a bit of it's a different job, which requires a different skill set. To my knowledge, there really isn't a good training curriculum for behavioral health crisis services. So through GBRICS, this is one of the things that we're going to be looking to try to build out to support our workforce, is to provide people with the ongoing training they need, and also try to find creative ways to attract people to want to come in to work in behavioral health crisis services. We haven't figured it all out yet, but some things are becoming evident. We need training. Our clinicians certainly need training on when they need to know when to do, for example, like an emergency petition, which is involuntarily requiring someone to go get an evaluation. That's done inconsistently across our field. But they're also looking for trainings on just how to be able to respond in the moment. And to our knowledge, it doesn't exist. So we'll be looking to try to help develop that.
That's great. So we did invite folks to ask questions in the chat, and we have about 15 minutes that we can take questions now. I'm going to start, and to my fellow panelists, I don't think you've seen any of them, so we're going to be nimble in real time here, answering questions. And so I'll just pick through some of them, folks. Anybody who submits a question in the chat that we are unable to get to, we will do some follow-up and make sure we get answers out to the participants from today. But we've had a couple good questions come in already. The first one, I think, Delegate Sickles, is a great one for you. And one of our listeners noted that they recalled Fairfax County Public Schools used to have a program called Teachers for Tomorrow. And might there be an opportunity to create a similar program for the field of behavioral health professionals in some of the Virginia public school districts?
Yeah, I kind of mentioned that earlier. I think that's the way to go. I think we definitely need that. We had that program in a small way for teachers. I think the questioner mentioned that. Dedicating, drilling down on it, highlighting it. I think it's a very good idea. It probably is the only thing that's going to produce real results in our underserved areas. So I'm going to pursue these things going forward. So thank you for that question and suggestion.
Excellent. One of the things, as I was thinking about high school students and, the requirements of non-English language development in schools, and how we think about creating, a pipeline of folks who speak more than one language, and might that help diversify our workforce? Is there opportunities in the school system for that as well? I think for any of you, are there other thoughts about the ways we could diversify the behavioral health workforce, both in what I would describe as, the composition and demographic of the workforce, but also more broadly across language and culture? Are there other areas that might stand out, or that you've thought about as we've been talking today about how we might be able to diversify the incoming workforce in that way? Rashna, you look like you've got a great thought to share. You're on mute though.
Yeah, I wasn't connecting. So one thing I think Adrian mentioned is that we work mostly with social workers and LPCs. It's a predominantly white workforce. So as much as we try to diversify our workforce, we are pulling from a fairly non-diverse workforce. So I think that one thing that when I was in healthcare, working in the hospital systems at Inova, we used to go to high schools. I myself had gone to a high school, to talk about careers in healthcare. And I think that's kind of what our listener was saying, is that we really need to reach people earlier, and especially in the rural areas. But I think if we were to also reduce the stigma of mental health care. So I think there's that piece about reaching out into the high schools, and catching kids earlier to spark their interest earlier. But I think as a society, we still need to reduce the stigma, particularly in some of these kind of more minority underserved areas. I do think there is more stigma in certain cultural groups or certain racial groups than there are in others, quite frankly. So until we take down the stigma in some of these communities, you're going to really have a struggle to get them to go into therapy to begin with if there's so much stigma there.
So Adrian, Rasha, you both have mentioned that we have today a predominantly white workforce. Is it also a fair conclusion to say that it's predominantly white and predominantly English as a primary language workforce? And one of the things we talk a lot about as a barrier to good health more broadly, not just specifically in behavioral health, but perhaps in behavioral health, there could be an even greater impact because of the need for a therapeutic relationship and communication, non-English. And if we don't have a workforce that is non-English speaking as primary languages, I think about trying to learn, as a health professional, try to learn all of the terms for, the human body, for anatomy, for all of the, various techniques. You just think about the sheer volume of information and complex terms that are not part of, what most of us grow up with. And if you layer in any kind of a language barrier on top of that, that feels like a pretty daunting thing for us to be addressing. And it strikes me that language is a really core part of our culture, whether that's in our small in the neighborhoods or family communities that we are a part of, but that language is really important. Is that a fair assessment that not only are we going to need to broaden the demographic composition of our workforce so that it better represents the people that we're serving, but also we're going to need to broaden the language of our workforce?
Yeah, I would say yes, hands down, yes. And it contributes to one of the reasons people don't reach out and access care. And I think it's that kind of also contributes to the historical approach that our system of care has taken, which is we expect the consumer to conform to our system rather than we go and meet them where they are. How are you to meet someone where they are if you don't even speak the same language? So, I think that's another component that could be part of an early training, whether it's in high school, but also in college. It was certainly nothing that was expected of me when I went to school for social work. Hey, you should learn Spanish. And I grew up in a community that had a large Hispanic population, but it was not something that was required of me. But maybe it is something we should start thinking about because it's part of being culturally competent and meeting people where they are.
Great. One of our other listeners asked, has GBRICS considered using digital therapies to improve access to mental health? This is a great way to diversify services that could bring care to the consumer. Is that something that the crisis response system has looked at? Can you talk a little bit about that?
Yeah, absolutely, especially with the broader use of telehealth. We have providers within the system of care that can already use that, but one of the big components of accessing our crisis system of care is that a comprehensive call center. So a phone number that people can call to or call if they need help. We've got that in the state of Maryland. We've got several call centers that operate regionally. They're crisis call centers, but a lot of people call for looking for information about services across the community, but sometimes people call just because they're looking for someone to talk to, which is something we saw increase phenomenally over the course of this pandemic. We had a lot of people calling, just feeling grief because of loss or all kinds of loss, right? Loss of a loved one, loss of a job, loss of that connection. So the digital therapy, our call centers have been doing more of this digital therapy as a result of the pandemic. They had been doing it before, but they're doing more of it. And I think there's going to be, and there is an increased need for it. And I think it's going to be used more broadly. And it's certainly something we want to expand through GBRICS.
Terrific. So we're going to start what I'm going to call the lightning round. And if I want to make sure to give you each 2 minutes. If you have 2 minutes that you wanted to make sure to communicate something important around this topic to our audience, I would invite you, whether they're questions we've already touched on or if it's areas that we didn't touch on and should have. I want to give you each, an opportunity to speak to the audience about this in a way that's important to you. Rasha, maybe we could start with you. And I know you were totally unprepared for that, but we're practicing agility in real time here.
Absolutely. So something that's very much top of mind for me as we're preparing for 2022, our budgets, our staffing, our strategies, our priorities, is truly this, the disparity in pay for therapists. So in Northern Virginia, therapists that are in private practice are easily, charging out of pocket $175 an hour or more, $150, $200 an hour. And as a nonprofit, it is, we obviously cannot pay that much for therapists to take care of underserved people who don't have insurance, people who don't have jobs, people who are homeless, right? So I think it is so important for us to really think about how do we balance out how we pay our therapists that are in, private practice. Even we also take insurance, which is truly a social service, because not to offend people like Carefirst, but really insurance reimbursement compared to what therapists make in private practice, there's a huge difference in that. And then we have people without insurance that hardly maybe pay $5 a session. So for us as a nonprofit, we have got to find ways that we can pay our therapists more so that we can compete with private practice. And that's a real struggle. That's very much a real struggle. And he doesn't know I'm looking at him right now, but Delegate Sickles, kind of really think about that, please, in terms of how do nonprofits that serve the most underserved people, how do we pay our therapists to compete when they can be in private practice? It is just very, very hard. And that's insurance, even insurance reimbursement. It's a real challenge. So I ask everyone to really put their hats on this, because we have there's a dwindling workforce, yes, but it's dwindling even more for the nonprofits because we can't pay as much.
Okay. Adrian, anything from you? And then we're going to have Delegate Sickles bring us home.
Agree with hands down with what Rasha just said. Agree with that. The only thing I would also add that we haven't covered today in terms of workforce is the value of peers, people with lived experience. We have peers in the public setting. They do a lot of work engaging people, whether they're in the hospital and then getting them connected to care. We use the peer workforce a lot in our crisis services system and helping to ensure that people, post-crisis stay connected to care. So they're a huge part of the workforce for behavioral health. But again, there's not a long-term sustainable funding plan. Our peer services are grant funded in the state of Maryland and across the country. That's a lot of how peers are supported. It would be great from a policy perspective if we could look at seeing if there's a reimbursement strategy to create a more sustainable funding mechanism for that really important part of our behavioral health workforce.
Right. Delegate Sickles, how about you? Anything you'd like to add?
Well, thank you. I mean, those are some good ideas. I just want to say that every public-facing business wants to diversify their workforce now. It's not just in the medical services or behavioral health. Everyone wants to do that. So we're in a competition for talent, and we're going to have to start paying more if we want to do this. Now, we have a special responsibility to our Medicaid population. We're going through changes on how low-income people can receive healthcare services. We're trying to make sure everybody has a healthcare home. And I mentioned earlier our managed care program. We've got to make sure that the managed care program can hire therapists and provide these services to our Medicaid population. Now, when you get a job and you're over 138% of poverty, we've got these issues in the exchange to make sure and try to transition people to make sure they have a healthcare home. this is fundamental to getting behavioral health services. You got to have a healthcare home for your overall medical needs, and we need to make sure that this type of therapy and resources are available to folks that make 300% of poverty, who are now going bare because they can't afford $11,000 or $15,000 deductible. So we need to place this in a larger context of getting everybody health care generally, and then making sure that behavioral health is a routine part, everyday part of healthcare, serving our low-income worker community. Really love the ideas of peers and how to pay peers. That is something we need to work on. Continual life training, continuous improvement. We've got a long way to go in this area, particularly in our state, where as I mentioned at the outset, we're over-relying on institutional care. Nobody wants that, but we're having a hard time transitioning. That's our challenge. And I thank you for many good ideas today from the panelists.
Well, I thank you all. This has been a great discussion. We are just about at time. So, you know, on behalf of Carefirst and on behalf of the field, thank you all for sharing your unique insights and perspective on how we can collectively work together to strengthen the behavioral workforce. And to our audience, thanks to each of you who registered for this event. As we continue to face the challenges we've got ahead of us, Carefirst is committed to transforming the healthcare system to one rooted in delivering value and healthier outcomes for all. Everyone have a wonderful day, a safe holiday season, and thanks for joining us today.
Thank you. Thank you. Happy holidays.
Thank you. Take care, everyone.
So Stacia, thank you so much.
Oh, thank you for joining, Rasha.
Yeah.
Let's make sure